morning, everyone. Today I'm going to present my clinical comprehensive case. First of all, I want to thank all my professors, colleagues, and family, and everyone who helped me to finish this long journey. I will start with the case history. The patient's name was Ahmed Saad. He is married, 37 years old, and an employee. Moving on to the medical history, he was an AAST type 1 as he was systemically free from any diseases. His dental history states that he had previously extraction of tooth number 3-6 and multiple class 5 fillings and multiple class 1 defective amalgam fillings. BFM on tooth number 1-3. His chief complaint was that he felt severe pain on recently extracted teeth, bad breath, and bleeding while brushing. The patient presents with no oral habits or parafunctional habits. Now I'm going to talk about the clinical examination, which includes the extraoral and intraoral examination. Regarding extraoral examination, the patient presents with non-pronounced facial asymmetry, and here is the views we will be looking at. In the frontal view, we can see that the patient's 3/3 of the face from the hairline to the glabella, from the glabella to the subnasal, from the subnasal to the menton are equal, which give him a good aesthetic appearance. And the line, and the intercommissural line is parallel to the interpupillary line. Regarding the lateral view, the nasolabial angle was 90 to 95 degrees. The patient exhibits a convex profile. And the A-line drawn from the tip of the nose to the tip of the chin. The upper lip was 4 mm behind the upper lip, and the lower lip was 2 mm behind the lip, which was normal. Examination of TMJs yielded that the patient was asymptomatic TMJs with normal mouth opening ranged from 35 to 55 mm and no deviations toward any side swipe opening. Moving on to the intraoral examination, here is some preoperative photos of the occlusal view, frontal view, and finally the lateral view. Regarding intraoral examination, these are the points I will be speaking about. I start with the radiographic findings. When we look at this panoramic X-ray, we can see that there is a generalized horizontal bone loss, localized angular bone loss on distal tooth number 4-5, and normal trabecular bone pattern. And here is some periapical X-rays I will be using later in the fixed partial denture. That shows normal crown to root ratio 2:3 and normal trabecular bone. Moving on to the mounted diagnostic cast, which shows adequate inter-arch space. Periodontal findings show that my patient has a generalized pale pink with generalized physiologic pigmentation, generalized road margins and plump inner papillae, and there is a generalized stippling in attached gingiva and the core of the papillae, generalized soft and edematous consistency, and the patient did have bleeding on probing for 75%, and the gingival bitype was thick and scalloped. And here's the periodontal chart, which shows that the general probing depths ranged from 0 to 3 and the clinical attachment loss ranged from 0 to 2. Moving on with the final diagnosis, the diagnosis was generalized diffuse gingivitis confirmed by the bleeding on probing test and generalized periodontitis stage 1 grade 8. The prognosis was favorable as there was no pronounced bone loss. The caries risk assessment reveals that the patient was high caries risk patient, and we will talk about its protocol later. Here is the dental examination of the upper and lower arch. And this chart shows the multiple missing and the multiple caries lesions of the patient. The diagnosis yielded that the patient had an exacting personality according to house classification, and he needs fixed partial denture, root canal treatments, and fillings. Starting with the emergency phase in the treatment plan, because the patient was feeling a severe pain because he suffered from a dry socket. Here is the armamentarium used in the emergency phase. I started with curettage for the socket and removing the soft debris as food debris and promoting the blood. Then I used irrigation to remove the loose materials embedded in the socket. Then I packed the socket with zinc oxide pack. Finally, prescribing analgesics for pain relief. Then we have the periodontal therapy. Here is the armamentarium used. I started by non-surgical deployment supragingivally by the Jacquard scaler and subgingivally by 4R4L in the posterior region and 2R2L for the anterior region. Then irrigation with tetracycline. And here is the oral hygiene instruction, which was teeth brushing twice daily with fluoride toothpaste, flossing daily, mouth rinsing, using chlorhexidine twice daily, 30 minutes after brushing for maximum 2 weeks, and the patient was aware of the side effects of chlorhexidine. Finally, the patient motivation and xylitol mouth gum 4 times daily. And here is the pre-operative photos before scaling, and here is after. Moving on to the restorative treatment, here is the armamentarium used. This table shows the multiple class 5 fillings done with the first used type of etching and bonding system, which was self-etch bonding system 7th generation, type of composite, which was microhybrid compatible composite, as it has modulus of elasticity that provides flex to the tooth and prevent the pout. And incremental layering technique filling, which reduce the polymerization shrinkage inside the cavity walls. And here's the photos before and after. Next, we have multiple class 1 restorations using the same type of etching and bonding system with nano-hybrid backable composite tetric N and the same filling technique. And here is the photos before and after. Then we have MOD cavities made with the same type of etching and bonding, same type of composite material, and same filling technique. Finally, we have the last cavity, which was tooth number 1-4, and the cavity design was class 2. Before, during, after isolation, after. Moving on to the endodontic treatment, I started with tooth number 3-5, which was the first abutment of my fixed partial denture. The diagnosis yielded that the pulp was necrotic. I used the crown down technique for preparation and cold lateral condensation for obturation. And here is the table showing the number of canals, working lengths, initial file, and master cone. Here is the pre-operative photo, initial file, master cone, after obturation. The second tooth was tooth number 1-5, which was 2 canals, and the diagnosis also yielded that the pulp was necrotic. It was 2 canals and the same preparation technique, same obturation and same restoration. Working length, initial file, master cone. Pre-operative photo, initial file for both canals, master cone, and obturation. The final tooth was tooth number 4-5 with necrotic pulp and apical periodontitis, as there was some radiolucency and the patient didn't feel any pain. He was asymptomatic. Same techniques, but different restoration. preoperative, initial file, master cone, obturation, and here is the build-up, and the final restoration. Last but not least, the fixed prosthodontics. Here is the armamentarium used. I started with post and core for tooth number 15, which was 2 canals, and I started by Gates Gladden drills by sequence from 1 to 5. Then I inserted the prefabricated post with self-adhesive resin. I removed 2/3 of the gutta perca, leaving only 1/3.